Hi, everyone. I'm Ralph Young, a physicist at Interop Medical Corporation in Sunnyvale, California. Interop's the manufacturer of the Mobitron Flash Accelerator. We're very excited to be a sponsor of the FRPT, and more importantly, we're excited to be a sponsor of the Meet the Expert session. Today we have Dr. Emil Schueler from the Department of Radiation Physics, a division of radiation oncology at the University of Texas MD Anderson Cancer Center.
Thank you, and thank you for spending your lunch with us. I was asked here just to give a brief overview of our program that we have at MD Anderson and talk a little bit about how to get things started and what we think are important in that setting. But obviously, we can talk about a lot of different things when it comes to Flash RT and specifically with the Mobitron platform. So any questions is obviously very welcomed in this setting. But we know that, so Flash Radiotherapy, I think we all agree, and we know that clinical translation is here, whether you like it or not. And we do have the technology today to do this, both with protons and with electrons. For limited indications, yes, but for electrons, for example, I know many centers are pursuing trials based on cutaneous lesions on the skin, but we can also do intraoperative radiation therapy in that setting. In protons, irradiation in the plateau region is something that we can do with transmission beams, but there's also new exciting development there with conforming to the tumor with flash dose rates. But we have the FAST-01, I think it's being presented this afternoon. That's already been completed. The FAST-02, also conducted at University of Cincinnati with shoot-through technology with protons. Is another one that's where they're recruiting right now. And if you look at the electron side, we have the IMPULSE trial from CHUV looking at melanoma skin metastases with a dose escalation trial there. So we're also pursuing clinical translation at MD Anderson, but looking at it from a program perspective there and looking at making sure that everything is safe and feasible. It really comes down to making sure that you know what you're doing when it comes to beam diagnostics and beam dosimetry, making sure you have the safety systems in place in order to be able to deliver the doses that you think you're delivering and want to deliver, but do that in a safe setting. And another aspect to that is we don't know what constitutes flash. What do we need to do in order to elicit the flash effect? So, and again, then based on that, we need to be able to then go in and measure the individual beam parameters in a robust way for any type of delivery that we're doing, so that we then can look at the data that we have and see are there specifics in our delivery that elicit the flash effect and maybe even optimizing it. So we have. This was a list that Farr et al. Was publishing earlier this year, and just taking out the physics components of that, because the biology is obviously another big one, but I was only given a brief talk here today. But it comes down to the properties of the beam themselves, and then also how to deliver it. That comes into the treatment planning. But we don't know if there is a difference depending on beam type or dose rate above a certain level, overall delivery time, dose per pulse, those aspects to it. And beam delivery-wise, if there's a dose conformity or a threshold that we need to apply, as well as a dose rate threshold. And we obviously have the big discussion whether the fractionation works and dose distributions. So any type of program, or we have put a lot of emphasis to make sure that we can follow this and we have that type of detailed data in all our preclinical, and we can also we'll be able to do it when we do the clinical translation. So we can follow these, and if we find something in the future that might be very important for us to look at, we have the data to retrospectively go back and look at it. But so at MD Anderson, our program is relatively new, but we have made a lot of progress in very short time, much thanks to a lot of help, and among other things that we have utilized the Mobitron there to a great extent in this program to get that up and running. But our goals when we started off, and this was a chronological order. So when we started off, we set up these five goals that we had to investigate. So establish the technical infrastructure to conduct flash irradiation was obviously the first. Confirm the flash effect preclinically. Expand the understanding of the flash effect. Determine feasibility for clinical translation. And then establish the infrastructure for clinical translation if that was deemed feasible. And within the main objective of this, when we take that step, is for a safe and robust clinical translation of flash radiation therapy. And so for that reason, we put a lot of work and emphasis on making sure that the machine behaves as we need it to behave, and that we can trace any parameter in our dosimetry to make this as safe and robust as we can possibly do it. So I'm going to focus now mostly of this on the technical infrastructure and dosimetry and beam control in this regard. And as you probably all know, it's the high dose propulsed when it comes to electron flash that really complicates our dosimetry. And it complicates dosimetry, but it also complicates on the biological response, because we and others have data showing that the beam structure actually matters in the magnitude of the biological effect that you see. And when it comes then to be able to make sure that you're delivering your beam as you intended, you need to be able to look at your individual pulses. And ion chambers, transmission ion chambers, is what traditionally is used in our linear accelerators when it comes to electrons and photons. And we actually know that they can work as well when it comes to flash, even though they are saturated. So this is the work here on the left, the work from Peterson's group, really showing that you can model the relationship for a flash beam line and model the saturation effect therein, and then so that you are then able to use the monitor chamber for your beam delivery. Of course, you won't have any information there on a pulse-by-pulse basis when it comes to time resolution in that instance, but you can still use it for overall beam delivery. That works in a scenario such as scenario 1 here, where you have the same dose per pulse, always. But there's no such machine that has that, and so that complicates it. We have scenario 2, where you do have fluctuations in the dose per pulse, that then changes the saturation effects in the chamber, and then you suddenly lost your entire calibration. Or you have scenario 3, where we have a ramp up in the dose per pulse, or ramp down, but that there's an effect before you reach a plateau. And if you only deliver, like this example here, 10 pulses, that effect is gonna highly affect then your beam delivery and your doses you're delivering and how consistent you are between irradiations. So one thing that we have been working a lot on is utilizing beam current transformers to get to make sure that we can have a better understanding and monitoring of our deliveries on a pulse-by-pulse basis, but also this is the first step. System integration is the next step. But it started with some interesting data coming out from Rafael Muekle and the Tube group, looking at feasibility of using beam current transformers, that we then taken and we put these beam current transformers into the head of the LINAC so that we can then see on a pulse-by-pulse basis really the pulse structure, the dose per pulse, pulse width, instantaneous dose rate. We can analyze that in real time for each pulse that's being delivered. And so here you can see then there's 2 BCTs in the head of the Mobitron, and we really can be used then as you MU1, MU2 if you're relate that to how we're doing it clinically today. So we and others there have shown that the BCT response is linear with dose, is linear with dose rate, linear with dose per pulse, and really what I'm showing here, this is the toric signal versus the dose, and nice linearity on the upper and the lower. You calibrate them obviously individually from each other. And then the toric signal here per pulse and the dose per pulse. We again show in this setting a very nice linearity. And here we show data just up to 2 gray per pulse, but it just depends on where you measure your doses. Because obviously the BCTs themselves are not moved. It's only where your reference conditions are going to be. Another exciting aspect of the BCTs is actually that you can use them to monitor your energy as well. So that's another effect that you can have based on that you have that dual Tor design in the Mobitron. You can actually monitor the energy of your beam, which is one of the requirements we have on a clinical unit. The one thing that is missing from a BCT response there is still going to be monitoring the symmetry of a beam, which is something that is yet to be solved with utilizing BCTs only. But one thing that we can also look at then when we have these BCT responses, we have built a GUI ourselves to then allow this real-time feedback on the treatment delivery. So what we do for each irradiation, we put in our prescription. We then have a real-time readout of the signal from the BCTs, and directly after the irradiation has been done, we get this summary page showing, comparing then what was measured versus what was prescribed, and you get a little nice green box if everything went as well. And then you also then have something that has been pushed a lot on from various committees, is that you have a log of everything that you have delivered. So, and this GUI then also creates that log, so you have a very detailed log file for every delivery that you ever done. Another thing that we're testing out in this space as well is what are the interlocks that we need to have. So when we do this full clinical translation and having a fully clinical unit in this space, we need to have interlocks. Usually we have these interlocks, it stops the beam based on a certain percentage of the dose being delivered in excess of what was prescribed. But in FLASH, we don't, if a dose per pulse, for example, matters, then the pulse by pulse variation needs to be monitored, and is there an interlock that we should apply on that? And that's really where radiation biology will also tell us what parameters do we set as interlocks, and what are the action levels that we're putting there. But right now we are flagging number of pulses was wrong, which we fortunately have not seen, but we have then dose, frequency, pulse width, variation between pulses, as well as energy. But so this is obviously a very important aspect of the work that we're doing, making sure that we can deliver and monitor what we're delivering. The next step in that is going to be then integration of this. So it's going to be a current-based delivery system. So you go away from number of pulses being delivered to actual dose delivered. But it is one of the components that we're working around. So we have these, at MD Anderson, the entire program is built around these 5 sub-programs or focus areas, I would call it. But everything is really focused on then the clinical translation and the implementation of this technology in the clinic. But so development and establishment of flash beamlines is obviously one of them. Detector and beam monitoring systems, which I just talked about. Biological effects and mechanism, again, just to elucidate what we need to do in a treatment planning system or in a beam control system. Radiation biology is still what needs to inform us of what to put importance on there. And then obviously the optimization of the flash effect, whether or not there is an effect based on the pulse structure, which we have now starting to see more and more, as well as looking at are the differences even when it comes to particle type on the magnitude of the flash effect. I'm going to just quickly go through some slides here, but something that we've been working on, and our center equipment there is around the Mobitron. We're also looking at converting out the clinical linear accelerators, and we're bringing in the Radiotron also for a dedicated preclinical system. Detector and beamline monitors, in addition to the BCTs, we're also looking at both characterizing detectors and dosimeters, as well as informing on the next development steps that need to be taken within that realm. The biological effects, something we're looking a lot on, and we have a comprehensive program there, both when it comes to immobilization devices for our animals, as well as then actually conducting the animal trials and in vitro trials as well. And the mechanism of the flash effects is, again, something we trying to elucidate. And then the optimization of the flash effect based on particle type and based on pulse structure. But really, everything leads to our clinical translation. That's where what we work around. So we're trying to then direct our efforts within our other focus areas towards our clinical translation, but still to make sure it's a safe and robust response, and making sure that we can do this accurately. Introp and MD Anderson has a strategic alliance together in order to bring that into clinical translation. It's been very successful so far, and we are now within that realm have defined the SURFACE trial, which is a phase 1 study that we hope to conduct to get started in early next year. So it's a single and hyperfractionated dose-finding trial of patients with cutaneous or subcutaneous tumors, and we'll use then the 9 MeV Mobitron unit for this, with the primary objective of feasibility and safety, but really then to determine recommended phase 2 dose to be used, and looking at a separation between cutaneous metastases as well as primary tumors in that setting. And looking at also what's the incidence of dose-limiting toxicity defined within 28 days, and a bond design there in order to bring us further in a dose escalation trial. So we're working actively along that, but not to FDA can take time, and we're right there currently working with them to get this approved. But again, we want to be able to do this as safely and robustly as we possibly can. So what we have done is we designed a pig trial around exactly what we're going to do in the clinical trial. So this pig trial is not designed to push toxicity or finding the mechanism behind it. It's really to look at, if we do this single fraction, if we do this dose-response relationship in the single fraction versus multi-fraction regimen, that in the model that we have that is most representative of human skin, that we're not seeing any surprises. So it really is around that safety aspect of it. So we're using the Yorkshire pig, and we're looking then at our dose escalation that we've been proposing, and we're using it with everything from CT sim. So we put all the pigs through a CT sim in a vac bag, through patient QA, treatment, follow-up. And so some of the things that we are going to be looking at this setting is going to be comparing conventional and flash. And that's really the difference with these pigs. We're going to be actually irradiating 6 fields on each pig, which we're not planning to do on the patient setting. That's really the big difference. But looking at in the same pig, looking at comparing conventional and flash, looking then at the dose per fraction, the role of fractionation in that setting, fractionation intensity is another thing. We will be looking at every day versus every other day. We have clinical protocols on each. Is there an advantageous effect based on one of them? The volume effect, which we've seen data on, that plays a big role there. And we're also going to be employing the KRAS pigs, which is so you can do actually lesions on the pig to look at tumor responses in that setting as well. That part we haven't started with yet. We're still on the normal tissue responses there on pigs. But yes, and I've talked way too long. Sorry, Ralph. I think we can agree clinical translation is here, whether we like it or not. But our take on it is that it's vital to bring the field forward. What we get, the information we get from these first clinical trials, will then change how we focus on, at least at MD Anderson, on our different focus areas, to make sure we're in line with what is needed in the clinic, because that is our focus. While we think it's very interesting, and we have also research around the mechanism of the FLASH effect, this is not that part of our program. So really aligning it to the clinic is what we're trying to do. And so just to summarize a little bit what I've been talking about, so we have the technology for accurate and precise beam monitoring. We just need to get that out there and fully implemented. Radiation biology needs to inform us of TPS or treatment planning system development. Introducing a flash factor, I think, is very premature in this setting, because we actually don't know what even the magnitude of the flash effect is in different tissues, in different settings. And then what I always ask as well is, well, if I have all of these metrics in my treatment planning system, I still don't know from a clinical perspective what is a good plan or not. Questions in the next step of technology integration and clinical translation. Just again, because this talk was more focused then on the technical aspects, like how fast does our beam control system need to be? What limits should we put on our prescription? I think that that's going to be very relevant when it comes to just how we set all of that. Are we then, if we can only stop our beam between pulses, should we then set ourselves at delivering 10 pulses? Because in the normal clinic, we have that 10% dose. Our secondary safety system stops the beam if 10% excess dose has been delivered. Is that then what we need to do then to make sure we have that 10% level also in the flash setting? Or do we limit ourselves then in introducing the maximal flash effect, because if there is a dose per pulse effect that we need to take under consideration, and the fewer pulses you deliver, the better, then obviously that limits the entire potential of the field. That's questions that we need to go into, as well as how do we compensate? You know, if pulses are low, do we compensate with higher pulses? If we have a beam breakdown, how do we compensate? Those effects also is something that we're actively working on, actively looking at, to see what is the safe strategy to put into the clinical setting. I think that was my last slide, and obviously it's all about the team. We have a great team at MD Anderson, so thank you.
Yeah, terrific talk, thanks. So what is the accuracy for prescription of dose? And I mean, for now, that you can prescribe to like 0.1 gray or 0.2, or is there a number you can put on it for us?
So with the Mobitron system, we have the ability to change the pulse width dynamically. So we can go down to that level in our prescriptions, yes. But then obviously there's an effect of reproducibility in delivery as well, but that's on par with our clinical units, which is 2 to 3%.
Okay. And so you've shown very elegantly in the colon that you have to titrate the dose fairly tightly to see the sort of flash benefit, if you will, right? Do you expect the same in skin?
I think we've already started to see that in skin. The data shows that you need to be above a certain dose in order to see it. And then obviously in the end, flash also kills. So in the end, you will have the curves go together again. I think it's going to be very interesting now when we go into the realm of fractionation to see can we actually separate them further. I think that one of the major negative aspects of what we as a community has been doing so far is we've only looked at single fraction, and we've looked at endpoints that can only be induced with high dose deliveries. I think that also skews the discussion a little bit.
Great talk. Are you considering any treatment planning implementation, 3D planning, or is this all going to be sort of based on basic PDDs and lookup tables?
We have developed our own in-house treatment planning system. It's rudimentary. It doesn't need to be very advanced in this setting. But we model it in RayStation, so we model our beam in RayStation so we can have a treatment planning, and that's what we're going to have on the patient setting. That we're going to look at how we can deliver it and look at the dose rate distribution as well. Still don't know what to do with it, but it's a nice metric to have as well to hopefully be able to then correlate the toxicities that we see with a plan.
A question that has been discussed here by many speakers, but I also wanted to get your point of view. Do you think there's a flash effect in cancer cells? So do you need to? Is there some moderation of the effect due to flash delivery even in cancer?
It's one of the central questions, isn't it? Many, if not all, the mechanisms that have been proposed really should then also spare tumor tissue in this setting. I think that's something that we need to elucidate properly in order to get this forward. I think that's also when we're now doing our clinical translation, realizing the fact that we do not know everything and testing everything exactly how you will be testing it clinically, test it preclinically first, right? Don't try to draw conclusions based on something that hasn't precisely been tested until we know what the mechanism is. That's the approach that we do in order to circumvent that aspect of it. But there are papers out there that shows better response on tumors. There are a handful of data also showing that tumor tissue has a worse response with flash. And those are fewer and far between, but we need to understand why we see that in those specific settings so we can safeguard the clinical translation as well.
I mean, you can escalate the dose because of a protective effect, but do you need to escalate the dose?
Yeah, it's a good point, right? It's like even if there is a sparing effect on the tumor tissue, if the sparing effect is more on the normal tissue, again, that's we can draw advantage of that. But it also comes down to then how do we define our clinical trials to make sure we safeguard on such a response, right? So because if you have some weird data on your first clinical trials, it's going to be blamed on the flash delivery, obviously. So just, again, trying as much as possible, safeguarding against that and understanding it to the best of our ability before we just go headlong into the clinical translation step.
Thank you very much.
So right now, to enable flash with Mobitron, you simply just need to bring a new different console. You do not need to modify the device at all, right? Okay. All right. All right. That's fine. And I guess the shielding is not an issue here, right?
No. Well, obviously, so if you're going to be beaming on straight for an hour with a flash beam,
right,
there's no cut. But no, in the end, you're delivering the same dose, right? So, and this is also a 9 MeV beam.
Right.
So,
when you spread out those minutes, hours, weekly, that probably doesn't make any difference, I guess, right?
when we did these calculations, and it just comes up to numbers that I think we would fry everything way before that would happen.
Right. So this BC team, what you mentioned, the upper lower, is that an investigational device or is it something ready to implement?
It is already inside the head of the Mobitron.
Okay.
So I think that, correct me if I'm wrong, but everything that's being shipped out right now have those implemented.
Oh, okay, I see.
For FLASH research
Yeah,
purposes.
for FLASH.
Not our
Oh, okay.
standard.
But
I
it's
see.
it's so far not a system that is integrated into the beam control.
I see.
That's now where we're taking the next step
Right.
now when we've shown these nice data both when it comes to linearity in dosimetry
Yeah.
as well as in the temporal performance of that system. The next step there now is to integrate it and run the beam based on the BCTs.
I see. But right now, so you don't have any way to particularly monitor the amount of dose produced or anything, right? Because the monitoring chamber doesn't really work, right?
Well, we do that with the BCTs right now.
Okay.
Right, so we can correlate. You calibrate your BCTs the same way as you would an internal ion chamber.
Yeah, yeah.
Right, so you have your reference conditions,
Right,
and you
right.
calibrate to that, and then you apply output factors and SSD factors in order to get
I
away
see.
from your reference conditions.
Right. So what is the highest dose rate you can produce right now?
It depends on the SSD,
Yeah.
but we can go up to with our tuning that we have on our beam, we go up to about 8 gray per pulse, and then it's 120 hertz units.
Okay.
A quick physics question. I like the idea of monitoring with the toroid. It makes a lot of sense. You showed toroid linearity with dose. How did you measure the dose in that denominator?
The correlation there was done with the film.
With film?
Yeah.
Okay. All right.
Great. Well, thank you very much, Emil. Appreciate everyone coming.